So I'll just mute myself.
Hello, good evening, everybody. It's my great pleasure to be here this evening and talk to you on dual bronchodilators, the way ahead in COPD management. Today, being the World COPD Day, this topic goes well with the day, and I thank my Spula friends for inviting me to give this talk in this webinar. I thank them for this nice arrangements they have made for the webinar. I thank all the participants, every one of you, for your time and your presence. I am the solo presenter today, so I thought I'll just introduce myself briefly before I start presenting my presentation. I am DR.J.C.Sekar. I'm a full-time private medical practitioner practicing in a place called Vadamadurai near Dindigul. I'm running a primary care rural nursing home with 12 beds since September 1986. It's supported by 24-hour fully automatic laboratory, a computerized radiography, ECG, and spirometry. And I'm the convener and honorary secretary of Club Pulmonary Dindigul, which is devoted itself to the disseminating knowledge about pulmonology to doctors in and around Dindigul. The club was inaugurated way back in January 2014, and we are conducting regular, non-stop monthly meetings every month on the fourth Wednesday. We have finished off 82 meetings back to back, and we'll be going for our 7th year in succession, January 2021. We meet on the fourth Wednesday of every month. And even in our COVID times, we are conducting meetings through the virtual platform. That's about me. The topic for today is dual bronchodilators, the way ahead in COPD management. We know that COPD is the third leading cause of death, and it remains the only leading cause of death that is increasing in prevalence. The first and second causes of death, namely myocardial infarction and stroke, their incidence is coming back gradually. But COPD incidence is increasing year by year, and soon it will have the dubious distinction of occupying the first slot of the leading cause of death. And the 5-year mortality rate for COPD people is 40 to 70%, depending upon the severity of the disease. Severe COPD has a two-year mortality rate of 50%, and it's worse than many of the common cancers. And as per one statistics in the US, 2017, 4.5% of the population of the US are living with diagnosed COPD. Undiagnosed people, there will be many. And India is definitely going to be worse than that. Many a time, it's so pathetic to note that such a common disease, which has such an impact on the world's health, is grossly underdiagnosed and undertreated. The patients, when they have COPD in the initial stages, they think it's just ordinary cough, and they didn't go to the physician at all. And even if they go, the busy practice, the doctor may not find time to investigate him for his COPD. And even if he gets a good prescription of COPD, the patient may not continue to take the prescription. All these ifs and buts exist. So COPD is very poorly managed. So only such pathetic figures we have got going. It's increasing year by year. And as the disease progresses, the COPD patient goes to dyspnea. It's a really severe dyspnea that will impact his health, his movement, everything, his psychology. And at that time, if you are able to give him some respite from the dyspnea by giving good medications, he will be very much grateful and thankful to you. How to make this happen? How exactly can you beat the dyspnea? That's exactly what I shall be talking to you in the next 30-40 minutes. In the next 30-40 minutes, I shall be discussing the world COPD message first. Then I'll talk about the importance of treating COPD. I'll discuss about the role of bronchodilators in the management of COPD, and then the advantage of dual bronchodilators over the traditional single use of single bronchodilators. And I shall be quoting some studies in support of my suggestions. And finally, I'll give you my comment on the use of corticosteroids in COPD, and I'll finish off the carry home messages. And here we go. So as we told you, today is the World COPD Day 2020. COPD Day is observed every year on the third Wednesday of November. This is the 17th or the 18th day. It's being observed by the GOLD, which is the Global Initiative for Chronic Obstructive Lung Diseases. And this year's message is living well with COPD, everybody, everywhere. It's such a positive message. All the patients with COPD and people who attend on COPD, everybody, they should live well. You can see bright sunshine there in the picture. There are no smoke, there's no vehicles, no auto rickshaws or buses or cars, only a cycle is going there. Green trees are there, beautiful sunshine and clouds. Nice picture. Give you a positive impact. And goal doesn't stop with that. It gives you four important ways in which this can be achieved. We know dyspnea is a major cause of anxiety in COPD. Patients should be offered guidance on self-management of dyspnea, including energy conservation, breathing techniques, and stress management. In addition to that, they should be properly vaccinated. Vaccination can reduce serious illness, such as those caused by the lower respiratory tract infections and death in COPD patients. In addition, they have been shown to reduce exacerbations. In addition to regular vaccinations, they recommend pneumococcal vaccinations, the H1N1 vaccinations, etc. Even in the 2021 guidelines, which has come just a few days back, the GOLD has advised injection of DPT vaccine, which we used to have in the childhood days for diphtheria pertussis vaccine. That has been advised. The new list added in this recent recommendation, 21 recommendation by GOLD, for those who had not been previously vaccinated, who had not their DPT vaccines. And COPD action plan is very important for all the patients. They should know when to report to the doctor, how to manage themselves, how to protect themselves from exacerbations of disease. Once their cough gets protective and stained, color becomes yellow or green, attend doctor, how should avoid those things, how to manage early phase of exacerbations, everything. They should have a thorough action plan. They should not get confused. And mental health is very important because depression and anxiety are very common, important comorbidities in COPD. They are often underdiagnosed and associated with poor health status and progress. Patients who have been productive all the years but smoking all the years, they had been doing so. Suddenly, they are deprived of their health. Even for walking, they have to be very dyspneic, and they'll depend on other people for their medical expenses. That throws them into typical depression. And a doctor who's attending a COPD patient should never think that others will be giving him mental support. You should be the first one to give him that. A warm pat on the back, nice words with a smile, and more importantly, not to interrupt him when the patient is talking. Should allow him to complete his own list of complaints. All these will go a long way in keeping up the mental health of the patient as fast as we are doing it. And last one but not the least is the inhaler use. Different types of inhalers are available, we know. There are beautiful inhalers, but which to give the which person is very important. And that too, again, every time the patient comes to you, you should be able to check whether he uses the inhalers properly. Be it PMDAs or DPIs, whether he uses it properly. Every time it comes to the patient, you should check. Then only it will be 10% useful. And why is this World COPD Day important? There are more than 300 million current cases of COPD in the world. And COPD is currently the third leading cause of death globally and is highly prevalent in lower resource countries. Exposure to tobacco smoke and other inhaled toxic particles and gases are the main risk factors for COPD. Although this is another thing which is coming up recently, suboptimal lung growth before and after birth can increase the risk of COPD later life. A lot of research is going on. It will come soon. The results will come. And this year's theme, living well with COPD, everybody, everywhere, it looks to send a positive message to both patients and health providers that although there's no cure for COPD, there are many ways to actively live well with the disease. So this, as far as the World COPD Day message is concerned, this is another slide from the World Lung Day, 25th September. This again tells about the COPD how 384 million people are affected, that 3 million people die each year of COPD, third leading cause of death, and it's more so in the low resource countries. And you should remember, every 4 minutes, someone dies of COPD. Yeah, that's very, very important. And smoking and COPD in the United States, smoking is the believed to be the cause for 90% of the patients with COPD. And in men who smoke, they are 26 times more common to have COPD than men who don't smoke. And as far as women is concerned, women who smoke, they have got 20 times more likely to suffer from COPD than women who don't smoke. But usually in the West, they say that men have more cases of COPD than women. But in India, things are different. Exposure to biomass fuel is the major risk factor in India, and more so in ladies. So for COPD in developing countries, especially in India and the Southeast Asia countries, in the village side, women are equally affected by COPD. Next time when a lady comes to you with chronic cough, please investigate for COPD. It's very, very important. Many times we think that women don't get COPD, but it's not the case. COPD epidemiology is also very important. In US and Europe, smoking is the main cause with cigarettes and cigars, whereas in Asia and Africa, cooking and heating biomass fuel is very important. This has been made very clear by a lot of studies and papers by especially Dr. Sandeep Salvi sir of Pune, is a leading pulmonologist in India, as a global face of India, global India to the gold. He is a member of gold also. He's done a lot of studies and proved beyond doubt that how the biomass fuel is so important in causing COPD in women especially. So next time a lady comes to you, please investigate, ask questions, and be sure that she doesn't have a COPD. Just two small slides on reduction of COPD. We know about it. COPD is a common, preventable, and treatable disease characterized by persistent respiratory symptoms. This is a very important, persistent respiratory symptoms. This is in stark contrast to bronchial asthma, which has got variable symptoms. In COPD, once you start getting dyspnea, it never goes back. It persists, it's there day in and day out, more when you exert, much more when you have an exacerbation. Whereas in asthma, in between the attack, especially, is absolutely normal. Absolutely normal. We won't believe he had asthma, severe asthma a few days or a few minutes ago. And airflow limitation, that's due to airway and alveolar abnormalities, is the cause in COPD. We know that airways, persistent bronchitis, chronic bronchitis, and emphysema are the two important traits in COPD which produce it. And symptoms of COPD, main thing is shortness of breath. That's what the patient comes to you for. There can be cough. At that stage, he won't come. Only when develops dyspnea is the primary symptom of COPD, and it's caused by blocked or clogged airways, as in chronic bronchitis, and damaged or disturbed alveoli, as in emphysema. So due to that, patient may complain of coughing, he may have chest pain, he may have fever and weight loss, and as I already told you, he will be depressed. Patients diagnosed with COPD display signs of both bronchitis and emphysema, both the traits, and experience exacerbations that can be really fatal if not treated properly. This is the pathophysiology of COPD. On the left side, you see a beautiful lung alveoli, normal. The airway is held open by alveolar attachments, which are quite strong and look so beautiful. Whereas on the right side, you see COPD lung. It's disrupted alveolar attachments because due to emphysema, there's mucus hypersecretion and luminal obstruction is there, which produces severe dyspnea. The mucosal and peribronchial inflammation and fibrosis over a period of time, it leads to obliterative bronchiolitis. And stage of COPD, the stage 1 is very mild with FEV1 about 80% or more of normal. Commonly in this stage, COPD causes slight airflow limitation. And even with this spirometry, even at this stage, you can diagnose COPD. And it will be a real victory for you if you do it so. Because if you diagnose stage 1 COPD, patient can lead almost a normal life after that, if he follows your advice. Stage 2 is moderate with a FEV1 between 50 and 80% of normal. Usually during this stage, most people seek help for COPD symptoms of coughing, wheezing, and shortness of breath. Stage 3 is severe COPD, emphysema with FEV1 between 30 and 50% of normal. Typically, in this stage, COPD symptoms worsen, causing decreased quality of life. And stage 4 is very severe COPD with a lower FE1 than stage 3, or those with stage 3 FE1 and low blood oxygen levels. Generally, this stage is known as the end stage COPD, meaning the disease has progressed, lung function has deteriorated, and flare-ups could be life-threatening. But we don't give much about staging nowadays because I'll discuss you in the future slides. You can see this old man using a spacer with an inhaler and a mask. You should be very careful to choose your mode of delivery of your inhaled drugs in COPD patients. It's no point to prescribe a deep tripod inhalation for a patient who has got very limited lung capacity or who has just can't suck in the air. It won't be prudent to give him a patient who's got tremors or who can't hold a mouthpiece in his mouth. You can't give him an inhaler when there's poor hand mouth coordination. In those patients, the best thing will be a spacer and an inhaler like this. So many times, even though drugs we prescribe for the COPD is normal, is correct, the mode of delivery is inhale is very important. Every time we prescribe, should assess the patient thoroughly, and then only you should give the prescription for a inhaler device, which is very important in COPD. And COPD doesn't come alone; it comes with a package. Many times the patient can have a cardiovascular disease, it can have a heart failure, it can have myocardial infarction, angina, valvular heart disease and whatnot. And he'll have osteoporosis because of limited movements and old age, decreased health conditions and asthenia. All these things leads to osteoporosis, which leads to more pain, body pain, back pain, etc., etc. And if not attended to, it will get worsened day by day. It will lead to a vicious cycle. And muscle wasting also will be there. You can't move about. Dyspnea leads to more muscle wasting, and muscle wasting leads to more dyspnea. Again, a vicious cycle. And underweight and obesity also will be a part and parcel of COPD. Those who come from the chronic bronchitis trait, they'll be underweight. Those who have emphysematous may have maybe obese. You know, we have studied the pink puffers and the blue bloaters in the good old days. And metabolic disorders also are there to stay. The patient, when you diagnose as a COPD, should always screening for diabetes, for lipids. He may be diabetic, he may have lipid disorders, he can have a hyperuricemia, because all these diseases go as a package ahead of chronic inflammatory diseases, and we should be able to treat them also effectively. In fact, all the patients whom are diagnosed with COPD, they invariably go for ECG and all these tests, and if needed, I send them for echo also and abdominal scan also. And anxiety and depression are very important, as I already discussed in detail. Patients of COPD are really depressed. And how to overcome these things? You should give them psychological counseling. It's already poor, you have to spend on its drugs. You can't refer to a psychiatrist every time. You should do psychological counseling most of the time. You should give them exercise training properly. You should give them physical activity coaching, nutritional counseling and modulation. You should give them proper drug treatment, pulmonary rehabilitation, as we call it. All these things only will make a comprehensive treatment of COPD. And this is the GOLD guidelines 2018. It gives the general pharmacological recommendations for patients based on their GOLD classification. It divides the patient into two groups: those who have no or at least one moderate exacerbation of COPD per year, not leading to hospital admission, and another group who have got more than two exacerbations or one exacerbation severe enough to need hospitalization. In these two groups, if the in the first group, if the MMRC scale is between 0 and 1, MMRC is the modified Medical Research Council dyspnea scale. It ranges from 0 to 4. Or if the CAT score, the COPD assessment test, that ranges from 0 to 40. If that CAT score is less than 10, it's group A patients. They need a bronchodilator, SOIS. You can go for a short-acting bronchodilator even if they need be. At the same time, in this group, if the MMRC score is more than 2 or the CAT score is more than 10, you'll have to go for a long-acting bronchodilator, which is usually a LABA or a LAMA. And group C, who had more than 2 moderate exercise patients and whose MMR score is 0 and 1 and CAT score is less than 10, you'll have to go for a LAMA. This is the 2018 gold guidelines I told you. And when there are more than 2 exercise patients and the MMR score of more than 2 or CAT score of more than 10, then they come under group D. You have to give him a LABA plus LAMA, or given ICS and LABA can be given depending upon the eosinophil count. That's what the guidelines on 2018 has guided us. Now, this may be confusing. Now we'll start with a case. This will make things very clear. This is one Mr. X, is a 60-year-old male. He presents with disabling breathlessness. He gives history of 20 pack-year history of smoking. His post-bronchodilators parameter results are, and FE1 by FEC is just 0.5. FE1 is less than 50% of the particular value. And his comorbid condition is hypertension. He's been prescribed in ICS and LABA by the previous physician. He presents to you with disabling breathlessness, is not able to leave the house. He's so dyspneic. His echocardiography, his kidney function test, his LFT, his HbA1c, everything is normal limits. Then how do you go about this case? What's the next step? Should always remember the symptom burden of COPD in Indian patients, especially cough is one important symptom. About 58% of the people complain with cough. Major thing is breathlessness only. About 78% complain with breathlessness, and others tiredness, mucus on coughing, chest, weight loss, everything will be there. And they usually present with a mixture of all these symptoms. But the troublesome symptoms that patient experience is usually cough and breathlessness. That's how it happens. This was a oral presentation in the NAPCON 2016, and it comprised of 245 patients. It's a very useful presentation. And breathlessness is the most troublesome symptom of COPD. In more than 80% of the COPD patients had moderate to very severe COPD during their first diagnosis. This is also very important, especially in India. Breathlessness, exercise limitations, impaired quality of life, and high risk of exacerbation, they exist across all goal stages. This is the MMRC score. You can see it ranges from 1.3 to 2.3 over stage 2, stage 3, and stage 4. This is the distance which a patient can walk. It's only 405 meters in the stage 2 patient, 356 meters for the stage 3 patient, and the stage 4, it's just 289 meters. That's the average distance which patient could walk. The number of exacerbations which the patient had, again, it's common. All the 3 groups in the stage 2, it's the mean number of exacerbations 0.6. In the stage 2, it's stage 3, it's 1, and in stage 4, it's 1.2. And the SGRQ, the St. George Respiratory Questionnaire Dyspnea Scale, this also is quite high in all the 3 groups. And when asked to describe COPD in one word, the respondents will tell you it's hard, it's difficult, it's depressing, it's terrible, it's annoying, so and whatnot. So many things they complain. And only then they realize that what a grave mistake they have committed by smoking, or they've been due to their occupation, what has happened. And it's the downward spiral of dyspnea. Dyspnea with activities initially will be very good, but once the patient gets more dyspnea due to activities, it goes down. It becomes more sedentary to avoid dyspnea, producing activity, and it decreases activity. And decreased activity again increases dyspnea. The decondition aggravates dyspnea, and patients adjust by reducing their activity still further. It's a vicious cycle. The pathophysiology of obstruction and airflow impedance COPD is mainly to inhaled noxious agents. We know about it, cigarette smoking and biomass fuel and pollutants. There's extensive lung damage which happens over a period of time, not on a day or two, but over years and decades. It's mainly a small airway disease, airway narrowing and fibrosis. Parenchymal destruction, there's loss of alveolar attachments and decrease in elastic recoil, which leads to emphysema. Mucus hypersecretion, which is a classical of chronic bronchitis, all these combined together to produce obstruction and airflow limitation. And where do the bronchodilators come here in this? The inflammation, oxidative stress, the tissue repair, it goes to expiratory flow limitation, hyperinflation, dyspnea, again a vicious cycle. Here, the bronchodilators they act as a pivotal role in the expiratory flow limitation. That's the treatment for COPD, and it prevents further hyperinflation, prevents further dyspnea, and deconditioning and inactivity and decreased exercise capacity, everything is prevented. The role of bronchodilators in the management of COPD is very vital. They're essential to symptom management in COPD. They decrease the air trapping, they decrease the bronchoconstriction, there is smooth muscle relaxation due to LAMAs, the increased mucociliary clearance occurs, and due to LAMAs, there's reduced hyperinflation, there's improved respiratory muscle function. All these things happen. And bronchodilators actually deflate the lung. As you can see in this cartoon, by bronchodilatation, there's increased airflow. There's improvement in flow, FE1 is increased, improvement in volumes, FE1C and IC and inspirator capacity are increased. And we know commonly used bronchodilators, they belong to two major groups. One is the beta-2 agonist, and another is the muscarinic acid antagonist. One is an agonist and there's an antagonist. Beta-2 agonist combine with the beta-2 receptors and convert the cyclic adenosine triphosphate to monophosphate within the smooth muscle cells, causing bronchodilation. The short-acting things which you usually use are salbutamol, levosalbutamol. The long-acting, which are called as LABAs, are actually salmeterol, formoterol, and indacaterol. And muscarinic acid antagonists, they inhibit the resting vagal cholinergic bronchodilator tone by blocking muscarinic receptors, thereby producing bronchodilation. They also reduce mucus hypersecretion, and they block the increase in cholinergic tone secondary to viral infections. The short-acting ones are ipratropium and triotropium. The long-acting LAMAs are glycopyrronium and imiclidinium. The mechanism of bronchodilator action of antimuscarinic agents and the beta-2 antimuscarinic agents block the binding of acetylcholine to M3 muscarinic receptors. Just now I told you, and they inhibit the smooth muscle cell contraction. Beta-2 receptors agonists, the beta-2 adrenergic receptor, they induce the cascade of signal transaction events and leads to smooth muscle relaxation. The role of, so when they combine both together in COPD, they act in a beautiful way. Two different molecules, two different mechanisms. Cholinergic activity mediated bronchoconstriction is the major reversible component in COPD is being taken care of. Increased bronchodilation leads to synergistic action targeting different receptors. There's reduction in hyperinflation, stimulation of the airway, decreased mucus production and increased mucociliary clearance, improvement of symptoms severity, and anti-inflammatory properties. Everything goes together hand in hand. So when you see the COPD patient perspective, the key findings is a major study, questionnaire-based study performed in the European countries, the population with asthma and COPD. About 720 patients took part in the study, and what they told was 53% of the patients, they notably reduce physical activity for fear of breathing difficulties. As I already discussed, once you reduce the physical activity, it will increase their breathing subsequently. And 60% of they have difficulty in walking up the stairs or walking due to COPD. 50% of they are afraid of COPD worsening as the cold season comes. Because of COPD, 23% of the people feel they are the burden on the rest of the families, which is really pathetic. And 37% of are always afraid of not having the medicine for COPD with themselves. And one of the major concerns in India, not in India, but throughout the world, is delayed diagnosis of COPD in India. The SCOPE study, survey of newly diagnosed COPD patients, it was conducted in the year 2014 and was presented in NAPCON. Survey of 47 pulmonologists across India, data obtained by 247 newly diagnosed COPD patients. The key finding was the first time a pulmonologist sees a COPD patient, the patient is already in the severe stage of COPD. It's the severe stage. But as I already discussed in the first slide, the patient delayed to come to the doctor. And if he even comes to the doctor takes some time to diagnose COPD. And even if doctor gives a good prescription of COPD, it's not being followed properly. All these things, they aggravate the COPD. Physicians and general practitioners, being the first point of contact for all health-related issues, including COPD, need to identify COPD in the early stages. I told you, spirometry, which is still a grossly underutilized investigation, even today, can diagnose COPD right from stage 1. And once you diagnose COPD in the stage 1, you can live almost a normal life during the rest of his life if he follows the advice. And early diagnosis along with subsequent pharmacological therapy may help in reducing the morbidity and mortality of COPD. And majority of the doctors reported that Patient with COPD, visit them at moderate to severe stages of COPD. This just I told you, 90% of the GPs and physicians report that, and 82% of the pulmonologists report the same. This is a 2016% paper presentation. And many patients continue to experience breathlessness with monotherapy. When they're given only one bronchodilator like a LAMA or a LABA, the real-world study of patients with COPD, it shows that more than 80% of the patients, they applied all severity groups, more effective bronchodilation would be beneficial for them. The LABA, LAMA, FDC could address this need without having to add ICS. The need of dual bronchodilation is so very clear. Given the complexity of COPD, it's possible that a single drug may not possess all necessary pharmacological activity to result in the same therapeutic effect. And in patients not fully controlled with one long-acting bronchodilator, maximizing bronchodilation, that's adding another bronchodilator with a different mechanism of action, is the preferable option. And this is the evolution of therapy in COPD over the decades. In 1960, it was the salbutamol to come first, then phenobarbital, then ipratropium came in 70s. In 80s came the oxytropium. 1990s saw the salmeterol and the formoterol, which made a good mark. And in the 2000s come the formoterol budesonide combination, which still has a very good usage throughout. Tiotropium, levosalbutamol, formoterol, bectamidine also came in this decade. And in the 2010s, you got roflumilast, you got aclidinium and glycopyrronium, which is a really long-acting drug. Indacaterol and glycopyrronium came in the 2013. It was a big winner right from the start, but for its cost was a very useful drug to use. And imiclidinium by 2014, and formoterol and glycopyrronium, the combination which we'll be talking about today, came in the year 2017. It's the latest entry. So this is the 2020 gold guidelines for COPD patient. It puts off with the group A, group B. It puts off the stage 1, stage 2, nothing is there. If the response to initial treatment is adequate, maintain it. This slide you should all remember. If the response to initial treatment is not adequate, then you should divide your patients to two broad groups. Patients who have a predominantly dyspnea trait, or patients who have predominantly exacerbation trait. If the patient has both dyspnea and exacerbation trait, you can include them in the exacerbation trait. You can see boxes in every group. Whatever drug patient is taking at present, you put the box in that, and you can follow the arrow to go to the next level. The patient who has a predominantly dyspnea trait has a LABA or a LAMA not controlled adequately, follow the arrow, go to LABA-LAMA combination. Or if he has a LABA plus ICS not adequately controlled, follow the arrow and go to LABA-LAMA again. And you can go for LABA plus LAMA plus ICS. This is what it goes. So if all the drugs, LABA-LAMA is not controlled, you consider switching inhaled devices or molecules, or investigate and treat other causes of dyspnea. The patient belongs to the exacerbation trait, and is not a LABA or LAMA is not controlled, then you can again follow the arrows. The red square is the preferred one. Go for a LABA and LAMA right at start. Don't wait for a stage A or stage B or group B or group B, nothing. Give him a good life, give him good freedom from dyspnea. Start and a LABA-LAMA combination. If the patient is already on LABA and ICS, then switch him to LABA-LAMA. Or all this, just put him in the box and follow the arrow. That's what it says. And you can consider the eosinophily also. If the eosinophily is more than 100, go for an ICS. If it's less than 100, go for other drugs. And roflumilast will be very useful in this patient who are resistant to these three drug combinations. And if there seems to be infection, and for former smokers, will go for azithromycin. This is the latest 2020 gold guidelines. And which dual bronchodilator should be given to these patients, and whether it should be given once daily or twice daily, we'll have a quick workup on this. The preferred combination is glycopyrronium and formoterol. This is the latest entrant, as I told you. Glycopyrronium is a low oral bioavailability. It has a rapid onset of action, or start acting in just 6 minutes. It's a faster dissociation from M2 receptors compared to tiotropium. It's a 10.7-fold selectivity for M3 is to M2 receptors, as compared to 4.32-fold selectivity for tiotropium. And formoterol, we all know, it's a wonderful drug. It's rapid onset of action. It's a beautiful LABA, start action in just 5 minutes. Maximal bronchodilation within 30 minutes of post inhalation. There's improvement in lung function parameters, including FE1 and inspiratory capacity. It reduces need for rescue medications, which is very, very important. It reduces COPD exacerbations and improves health-related quality of life. And selecting the right dose of glycopyrronium and formoterol also will be a great concern. Glycopyrronium at a daily dose of 50 micrograms gives non-inferior bronchodilation as compared to tiotropium with rapid onset of action. This we have seen when compared between glycopyrronium and tiotropium. The 50 microgram and the minimum total daily dose of glycopyrronium required to achieve a clinically significant improvement in the lung function. And 60% of the Indian COPD patients experience nighttime or early morning symptoms. This study shows very clearly that in the daytime, 20% of the patients had dyspnea. Nighttime it was 27.76. Early morning it was 33. And throughout 24 hours, depending on severity, people had 32.65%. The main thing to focus is here, nighttime and early morning. So it wakes them up at night, and they are sleep disturbed, and it leads to more anxiety, more weak feeling, dissociation of health, everything happens. So the part of the day when the patient experiences most symptoms is usually nighttime and the early morning. And twice daily dosing. Glycopyrronium was given as once daily dosage, 50 microgram along with indacaterol previously. But when you split the regimen, give it as 25 microgram BD, twice daily dosing regimen is more favorable as compared to once daily regimen, as this study shows clearly. The blue line shows the BID dosage is superior to OD for trough FP1. The BID dosing may offer greater improvement in nighttime symptoms. The pink one is the lower one, and the blue one shows clear benefit. This study contained 385 patients. And twice dosing regimen of glycopyrronium takes care of the nighttime symptoms also in COPD patients. When you give 12.5 microgram BD compared to 25 microgram OD, you can see the MCID for FE1. MCID is minimal clinically important difference for FE1, which is 100 ml. It far goes down below that in the first graph. But when you give a 50 microgram dose of glycopyrronium, it is almost normal with both doses. But the 50 microgram OD dose has a small dip below 100 in the early morning, in the 18 to 24 hour gap period. Whereas when you give us 20 microgram BD, that doesn't occur. It stays well clear of the MCID for FE1. So BD dosing helps maintain FE1 and helps nighttime symptoms. This study shows very clearly that, and both 6 microgram and 12 microgram formoterol BD causes a significant improvement in FE1 at 60 minutes post-dose. Now we have decided about the dose of glycopyrronium, and then we go how to decide at the dose of formoterol furoate. Can be given as 6 microgram or 12 microgram. They act almost equally only. Not much a difference. And actually, 12 microgram is better than 6. The following slides will show you that the 12 microgram formoterol BD results in greater reduction in use of liver medications and improvement in quality of life of the COPD patients versus 6 microgram formoterol BID. And symptom-free days significantly increased with 12 microgram BID formoterol, but not with 6 microgram BID formoterol. This study shows but that clearly for placebo, symptom-free days are just 6.5%, whereas with formoterol 6 microgram BD is about 8%. For 12 microgram BD is almost 12, and for 25 microgram is still higher. And the significant effect on breathlessness and chest tightness with 12 microgram BD formoterol, but not 6 microgram BID. This study also shows that all things, sleep disturbance, breathlessness, cough, chest tightness, total symptom score, everything is improved. It's much more convenient if we use a 12 microgram formoterol than a 6 microgram BD. And many international brands, they have got 12 microgram only in their brands. Symbicort Turbal is available. I'm using it extensively. Even that has a 12 microgram only. And 12 microgram BID formoterol is as safe as 6 microgram BID formoterol. There's no tachycardia, it's tremor, or almost as much or as good as or as bad as 6 microgram formoterol only. And tachycardia and tremor, known as the class effects of beta agonists, were reported in a very low proportion of patients with no evident dose relationship. And of the two compounds, the most common drug-related adverse reactions are the pharmacologically predictable side effects of beta-2 agonist therapy, such as tremor and palpitations. They tend to be mild and usually disappear within a few days of treatment. So it's better to give a 12 microgram. And this is the new evidence on dual bronchodilators in COPD management, the Pinnacle study. They come recently for major trials, which include a lot of patients. In the Pinnacle 1, it was more than 2,000 patients. In the Pinnacle 2, it was 1,600 patients. In the Pinnacle 3, it was 892 patients. And Pinnacle 4 was 17 patients, all conducted over a period of 24 weeks to 54 weeks. And all studies carried out in patients with moderate to severe, very severe COPD. In all of them, the combination used was glycopyranide and formoterol 18 plus 9.6. So they were divided into three broad groups. One group got glycopyranide and formoterol. Second group got only glycopyranide, and third group got only formoterol. And when you compare between the three, the Pinnacle 1 and 2 studies, glycopyranide formoterol showed a clear improvement of 6 ml more, if you want, than glycopyranide alone, 60 ml more than formoterol alone, and 106 ml more of FE1 when compared to placebo. The bronchodilator effect of glycopyranide formoterol is what persisted over the 12-hour dosing interval. And the change from baseline in morning pre-dose trough FE1 over 24 weeks were consistent regardless of concomitant ICS use. And glycopyranide and formoterol results in a significant improvement in inspiratory capacity as compared to tiotropium and placebo. As you could see very much here, when compared to placebo, this combination showed a clear 312 ml improvement in FE1. When compared to here also, when compared to tiotropium, it was 381 ml, here 335 ml. So inspiratory capacity was greater following the evening dose as compared to the morning dose. The onset of action of glycopyranide and formoterol was observed in 5 minutes post-dose. As soon as the patient inhales the drug, because of a quick onset of action, it means immediate relief. There's immediate increase the FA1 of 187 ml in Pinnacle 1 study. The FA1 was increased by 186 ml in the Pinnacle 2 study. The onset of action was defined as the first time point at which difference compared to placebo MDA for change from baseline FA1 was statistically significant. A rapid onset of action may allow patients to quickly perceive the benefit of a dose, which may also help to improve the treatment adherence. So, glycopyranide and formoterol combination resulted in greater reduction of in use of reliever medications and improvement in quality of life as compared to monotherapy over 24 weeks. This is again a large study. 1 puff per day change from the baseline in rescue medications used corresponds to reduction in moderate severe exception COPD patients. Patients treated with glycopyranide and formoterol MDAs, they were more likely to achieve a clinically significant benefit of quality of life improvement versus glycopyranide alone or a placebo points improvement in the SGRQ score. So glycopyranide formoterol is clinically beneficial in symptomatic patients. The improvement with the GFS with monocomponents and placebo increased with higher CT CAT scores. You can see this very clearly in this. When the combination of glycopyranide and formoterol was used, the CAT score was increased by went down by minus 3.7. Who had CAT score of more than 15, it went down by 0.44, and who had CAT score of more than 20, it went down by 5.1, which is much better than the other three groups. So the results of Pinnacle studies, to summarize, this combination of glycopyranide and formoterol improves lung function greater than the placebo. Glycopyranide and formoterol and tiotropium used alone. There's a rapid onset of action, 187 ml improvement in FA1 within 5 minutes. It improves morning inspiratory capacity by 335 ml and evening by 385 ml. It reduces breathlessness in COPD patients. It improves the quality of life. Is effective in highly symptomatic patients. 5.1 unit reduction in SGRQ score in patients with CAT score of more than 20. It reduces the rescue inhaler use, and glycopyranide formoterol does not cause any major adverse events or cardiac side effects even after treatment for 52 weeks. So this is a product which has been introduced recently by Cipla. Is the glycohale F. It can be used with the nebulizer rotahala. It comes in all pack to protect the glycoprotein from moisture. It has a patented pull and lift technology for ease of removing blisters and has individual cross perforations and the right dose of glycoprotein formoterol in the right packing. The only combination of glycoprotein formoterol with studies and Indian COPD patients presented in ERS 2019. So this again is another study, randomized prospective open label comparative parallel group multicenter 12-week study to evaluate the efficacy of glycoprotein formoterol 25 microgram plus 12 microgram twice daily combinations. The glycoprotein 50 milligram once daily in patients with moderate severe chronic COPD. So active this is the combination which came in glycohale. The active comparator was glycoprotein alone, 50 microgram once daily dosage. So totally 515 patients screened, of 350 were enrolled. This is the when the glycoprotein formoterol scored much higher than when glycoprotein when used alone. As secondary endpoint also, it shows very clearly that glycoprotein formoterol scored over the when glycoprotein was used alone. In all three parameters, there's a mean change in the pre-dose trough FE1 at the 2, 4, and 8 weeks interval, the mean change in the 1 hour post-dose FE1, 2, 4, 8, and 12 weeks interval, and the mean change 1 hour post-dose FEC in 2, 4, 8, and 12 weeks of treatment. All those reported with this. And the secondary endpoint also, the mean change in the MMRC score at 4, 8, 12 weeks in treatment from baseline, glycoprotein was much better than glycoprotein when used alone. The difference in the daily number of PMDs puffs for rescue mitigation was much less, and the combination was used than glycoprotein alone. So it's a mean change in CAT score at 4, 8, 12 weeks. All these studies find that the combination of glycoprotein and formoterol was much better, faring much better than the glycoprotein alone. The number of adverse events also, number of adverse events is almost equal in both the groups. No serious adverse was found. The other safety endpoints were there is no clinically significant change in vital signs and physical examination. There's no the change in potassium values at 4 and 12 weeks from baseline is not clinically significant. There's no adverse event due to changes in serum potassium levels were reported. ECG pre-dose are not clinically significant as reported by investigator. There are no adverse events due to change in the ECG pre-dose that were reported. So before I conclude, a small comment on the role of IC. Many people may be having this question in mind, the role of ICS in COPD management. This is what the Goal 2020 updates are giving, that the triple inhaled therapy of LABA, LAMA, and ICS, it definitely improves lung functions, symptoms, and health status, and reduces exacerbations compared with LABA ICS or LABA LAMA or LAMA monotherapy. The triple combination reduces mortality also in high-risk patients. But when deciding whether or not to initiate ICS therapy, should consider the following factors. Then only she can start. It's not free for all. Should consider the frequency of exacerbations. Should consider about the blood eosinophil count. Should consider about the history of repeated pneumonias, hospitalization for an exacerbation, history of or concurrent asthma, history of mycobacterial infection. All these should be taken into account before you decide on administering ICS to your patient with COPD. So which things which strongly support the use of ICS will be history of hospitalization for exacerbation of COPD, 2 or more moderate exacerbations of COPD per year, blood eosinophils more than 300 cells. But you should always remember that eosinophilia can be caused in India for many more reasons than tropical eosinophilia or other things. Even your worms can cause you that eosinophilia. So you should keep all these things in mind. And history of concomitant asthma is a strong support for using ICS. Should consider using ICS in patients who have 1 moderate exacerbation of COPD per year, whose blood eosinophilia is 300 cells per milliliter, and you should not use ICS in patients who have repeated pneumonia events and whose blood eosinophil is less than 100 cells. So to summarize what I've been talking in the past 30 minutes, glycoprotein and formoterol is approved as a maintenance treatment in COPD. The total daily dose of glycoprotein is 50 microgram. BD dosing of glycoprotein maintains trough FE1 is very important. 12 microgram formoterol BD reduces rescue medications, it improves symptoms and the quality of life versus the 6 microgram formoterol BD. So only in the product we use as 12 microgram formoterol. The combination has been studied in 360 patients and has been found to be safe and efficacious. And even cost-wise is much less than the intacaterol and tolacapodium combination. So our ultimate aim will be to relieve the suffering of the COPD patient. I am breathing, and trust me, that's a huge accomplishment. That's what this lady says, and it's a duty, I think, to relieve her of the dyspnea, and hope my presentation would have helped you in some ways to do the same. So thank you so much for your patient listening. I am ready to take questions. You can also unmute yourself, and you can ask questions. You can give your comments, please.
Participants are requested to unmute themselves in case they have any queries. Dr. Sekar would be more than happy to take your questions. You can even post it on a chat box if you want to.
Yes. Yes. Thank you for all the time. I think there are more questions. We will close the session. I thank all the participants. Again, once again, I thank Cipla for their arranging this nice CME. Yeah.
Yeah, thank you, Dr. Sekar, for your time. Thank you for the wonderful session. And I thank all the participants for joining in. Thank you, everybody. Stay safe, stay healthy.
Thank you. Thank you, Amit. Thank you. Thank you. Bye-bye. Bye-bye, every one of you.